Am I seeing the red? All right. Hi, everybody. Thank you for attending. This is the third session of our COVID education series that's been put together regionally. Our first week was about the clinical care of COVID and sort of a background epidemiology of what's happening in our region. The second session was an infectious disease perspective of COVID, as well as the PPE and infection control. And today, I'm very excited about today's talk because this is focused around palliative care and perhaps some end-of-life issues and COVID. So today we do have three speakers. Our third speaker is having a little bit of technical difficulty, but we'll get her on. And I'm going to turn it over to our moderator today, who's Dr. Declan Rowan, who many of you may know. So I'm just going to read a bit of a bio for him. He is a family physician. He's the chief of hospice medicine at the Pembroke Regional Hospital and has a part-time community practice at Ottawa Centennial Family Health Team. He was previously the family health lead and of the Champlain Regional Cancer Program. And during COVID, he has coordinated the palliative care response of the Renfrew County Virtual Triage and Assessment Center. And he's also a very active member of our inpatient regional group that has been struck up during this COVID era. So with that, I turn it over to Dr. Rowan.
All right, thanks, Neil. And thanks everybody for coming and joining us on this talk today. And I'm delighted that we're talking about this. I think COVID has really brought palliative care to the forefront, and I think it's a really important topic. We've got a couple of great speakers with us today. We've Dr. James Downer and Melanie Spency, who's a nurse practitioner, joining us. James is going to go first. Just give a little bit of a bio of James. He's going to be speaking about palliative care with COVID in the long-term care setting, and he's a critical care and palliative care physician in Ottawa. He's currently the head and division of palliative care at the University of Ottawa, an associate professor in the Department of Medicine, and he's co-chair of the Pan-Canadian Palliative Care Research Collaborative and the chair of Ethical Affairs Committee of the Canadian Critical Care Society, and the co-chair of the Ontario Palliative Care Network's Educational Steering Committee. He has a whole bunch of papers and a whole bunch of grants that he's been principal investigator on, and he's very interested in decision-making, communication with the seriously ill patients and their families, palliative care for the critically ill, and very importantly, palliative care for the non-cancer illnesses. So James, thanks very much for coming and joining us today and agreeing to do this. I appreciate it.
Pleasure. Should I'll load up my slides then?
Yeah, please do. Yeah, and yeah, for this talk as well, we encourage questions. We'll try to keep the questions to the end of each speaker. If you do have questions, there's a chat box you can pop them into, and both myself and Neil kind of keep an eye on the questions, and we'll get to them then as well.
Yeah, again, and just understand the context of what we were asked to do today is I think talking a bit about end-of-life care and palliative care for patients with COVID. And then for obvious reasons, I think the main focus of this session is going to be on care that occurred in long-term care, acute care, and in retirement homes, because that's where most of the death obviously occurred. About 82% of all people who have died of COVID in Canada were residents of long-term care facilities. So what I've done is I've prepared a few slides just to talk around here. I'm going to try to go through them quickly and leave time for discussion. But you know, when we saw the pandemic coming, and one of the things that we learned, I think, from previous experience with pandemics like H1N1 and most importantly like SARS, is that although mortality might go up, it doesn't mean that palliative care volumes go up. In fact, on the contrary, for a good chunk of time, we saw the opposite, that palliative care referrals went down, and certainly palliative care occupancy has gone down dramatically. Right now in the Ottawa area alone, there are more than 20 empty beds in palliative care facilities. That's never happened. So you understand that there's a difference between, like, there's just because you're dying doesn't mean you're going to get palliative care, and just because mortality rate goes up doesn't mean that more people get seen by palliative care specialists or that the death is occurring in a palliative care setting. And that's certainly been true of COVID. So as deaths are predominantly occurring in long-term care settings and in patients transferred from long-term care settings, we sort of exposed and identified, I think, a number of the gaps that we knew were already there, but were certainly exacerbated or further exposed by the COVID pandemic. We've now sort of regionally gone in to help probably a dozen or more facilities between long-term care and retirement homes to do actual in-facility assistance because they had significant outbreaks. And just to sort of summarize, I'm going to talk a bit about some of the broader issues that we saw. I'm going to talk about what we did when we went in there. I'm going to talk about where we're hoping to go with all of this, because it's going to be, we sure are not over this at all. Sorry, I'm just getting a visitor here. Buddy, you better go. Okay. So number one, you've got gaps in physician care, which were quite substantial. So I think it's not a secret that many long-term care facilities, frankly, were not having physicians rounding or certainly rounding with any reasonable frequency. That did not get better with COVID. So in fact, people who are covering perhaps multiple facilities would then not go into any of them for fear that if they got exposed, that other facilities would not allow them in. In some cases, we found situations with physicians who were not rounding, but actually not available. And that was quite a challenge. Some of the physicians we found who were caring for patients were actually not very familiar with palliative principles and had quite significant reluctance to order even PRN medications for comfort care, which was a big issue in certain facilities, not in others. We've all heard about gaps in staffing levels, but I sort of group those more broadly into gaps in nursing, RPN, and PSW care, because that's the majority of people who are working at these facilities. Staffing levels were quite substantially affected by the outbreak, indeed. Part of it was people going down, getting sick. Others were staff that simply just were not willing to come in and work in such an environment, particularly given the fact that they could make the same or more money working at Sobeys. And finally, you know, when we were there, we were also noticing that some of the staff who were present were really not at all familiar with end-of-life care or comfort care practices. So we would be often seeing patients who were in quite obvious distress or having quite significant symptoms, and this had just not been appreciated by the bedside staff. You know, kinds of things that for us would be quite shocking not to have noticed. And in terms of experience with comfort care, you know, we would find situations with nurses. One of the homes we visited, when we suggested that a patient required injectable medications for their comfort, we asked the nurse, were they able to give that? And the nurse said yes. And we said, could you do it, please? And then it became apparent that this nurse did not know where to find a syringe. When we found a syringe, the nurse did not know how to attach a needle to it. We kind of gave up at that point because it was very clear that this person was never going to be administering medication in a way that was required for comfort by the patient. I think we've also heard a lot about management issues. And again, some of these facilities had, I think, very good management, and others had management that was not able to deal with the crisis that was in front of them. They were not able to troubleshoot around staffing shortages. They were not able to troubleshoot around issues in the kitchen in terms of feeding, ordering replacement medications, anticipating what might be needed as the pandemic set in. And so those were important levels of support given as well. And I don't think enough attention or comment could be made about the IPAC issues in these facilities. Again, I think that we've heard a lot about PPE shortages in these facilities. I'm just going to state out loud from my experience of the ones that we saw, and we saw all the ones that were really struggling. I actually did not notice, we did not see a lot of issues with PPE supply. That certainly the PPE supply appeared adequate the places we went. The facilities with the biggest troubles, they had so much PPE in their nursing stations that you couldn't sit down. Like it was on the chairs, it was stacked up, you know, to the rafters. The issue, I think, was not supply of PPE, but the fact that nobody seemed familiar with how to use it. They hadn't been trained. Those who had been trained had obviously forgotten their training. Even things that I would have thought were fairly basic notions were not being observed. So when we went into the first facility, there was, you know, on an outbreak ward, there were trays of communal muffins sitting there. And I guess, you know, you had the MRSA muffins, the VRE muffins, the influenza muffins, and the COVID muffins. And people were just reaching in and grabbing while wearing their PPE, eating this communal food. And quite a comment was made when I suggested that we just throw away the communal food and not continue to use communal food. Oh, I also neglected to mention the carrier of Tim Hortons coffee that was sitting there with a stack of cups that anyone could just grab and pour and mix their own. When we arrived, while we were donning our PPE outside the building, we watched a nurse in full PPE, walk out of the building having not doffed anything. She was wearing her mask, her shield, her gloves, and her gown, walk out to the food delivery guy who was delivering her poutine, take the food from him, reach under her gown, pull out a credit card, and hand it to him that he put into the machine, which he then handed to her with her gloved hands, punched in her combination, her password, to have it run through, handed the machine back. Nobody wiping off anything, nobody doffed, nobody gowned. Giant fans blowing on outbreak wards. No cohorting, patients routinely housed positives with negatives, and visitor restrictions not applied. So finding out that a patient that you felt was nearing end of life with obvious COVID symptoms, who was known to be COVID positive, and his brother had actually been there sitting in his room on his bed for 3 hours that day, unsupervised. I'm not clear how that person was able to get into the building, but it happened routinely. So these were the kinds of issues that we were seeing in long-term care as we went in to try to assess and address. So in coordination with the incident response team for the region, and offered staffing supports, management supports, and that was all coming from other individuals. We were more from the clinical side of things, and we did site visits to do what was essentially acute triage and management of patients. We focused on the COVID positive patients, but ultimately ended up seeing anybody who was COVID negative on an outbreak ward as well, because many, depending on the recency of the COVID swab, we had no reason not to believe that other people who were believed to be COVID negative were actually not COVID positive, given that there were no real IPAC or infection prevention protocols in place in some of these places. One of the things we found that was very helpful was, as we went to the wards, we would assess the function of the bedside staff and how they would respond to things. So again, it was a given that these facilities basically had almost no physicians rounding on their patients at the bedside. So they were relying on the nurses and the RPNs to round and identify any issues that were coming up and respond to them. So when we identified an issue, we asked the bedside staff to come and could you give this? And I already described, watching them try to sort of do it gave you a lot of information about whether you felt comfortable leaving a person in that situation to be palliated. And not infrequently, we would transfer patients to the emergency room just for comfort care. We also thought it was important to assess the stockpile of comfort meds. These facilities should have all had comfort medications on site available and not have to order them in. And some of them did, and some of them, it was definitely in a lockbox on a different ward, but nobody knew where it was, and nobody was sure where the keys were, and it was not something you would be able to get in a timely fashion. Most importantly, and certainly as we went on, we were really trying to always start with the end in mind, right? So we were the fire brigade. We came in to assess and address acute needs. We could come back and do it again a few times, but this is not a sustainable model. We were going to have to hand back to something that was sustainable. So if the physicians were not able to attend, could we get other physicians who would come in-house and round? Could we were the physicians willing to come in and provide that support and just needed a bit of consult support, and then we could help out that way? And really a lot of that depended on what we saw when we went in, what our interactions with the attending physicians were like, and what the availability of supports were in the region. So just telling you a bit about the triage itself, which was kind of a bit of a fun experience, because it's, I'm the division head for palliative care, but I'm also an ICU physician. So way back once upon a time, I did all this sort of mass casualty event training and various things that is just sort of not part of palliative care training at all. But then, you're sort of, so one day we went in to see a facility of almost 300 patients, and we were told there were 50 COVID positive patients there. And then on arrival, they had gotten a bunch of swabs back, and there was actually 131 positive patients. And we had, a good afternoon to see them. You can't see 131 people and do a comprehensive palliative care assessment in an afternoon. I haven't tried, but I'm pretty sure you can't. So what we did was really more of a mass casualty approach using triage principles. And for that, it was really, really nice to have a team that consisted of paramedics and people who are minded to do things this way. So they had cool little approaches and nice little tricks to make things efficient. And we would form a team of about 4 or 5 people, ideally. And what we would do is we would go end to end on a ward. And so we would form a team. So one person's we'd get a little food cart. We'd tape a garbage bag to one end of it, stack up gloves and extra gowns on it, and then one person would take a very condensed documentation sheet to record information on patients. We'd have a patient list of who was positive and who was negative, and then one person would be documenting. Everyone else would grab a oxygen saturation probe for themselves, and we'd just go into rooms one by one, take a very focused assessment for symptoms and signs of respiratory distress, lethargy, decreased PO intake, any sign that might be consistent with COVID. We'd slip a sat probe on their finger and look for desaturations. Because some patients were asymptomatic but satting poorly, we would identify them that way. We come out and document, and we just go end to end on the ward and flag anybody with abnormal vitals or concerning symptoms or signs. You get to the end of the ward, and then you go back over everybody you flagged. Anybody who had abnormal vitals or symptoms or something that concerned you, you go and talk to the nursing staff or the MRP, find out, is this a new symptom, or if they're lethargic or less responsive, is that new, is this atypical, have they had a deterioration? You would update and discuss with the family, review their goals of care, and then you make a decision whether you're going to try to initiate treatment plus or minus comfort care. You'd almost always add comfort care, at least as a PRN. If they had comfort care orders ordered and they'd received a couple of PRNs, I almost invariably put them on standing medications, simply because the deterioration was fast, and sometimes you needed to be sure that these people were going to get the medications. And in some cases, based on goals of care or the status of the patient, you really needed to transfer them to acute care, which we did. Most importantly, you would flag the people who need to be followed up and figure out who was going to follow them. So you're either engaging with the staff in the building if you could. Very often you would also engage with outside staff that were coming in, either with a partnered hospital or with family doctors who were being engaged for the purpose. Now, simplifying things a little bit, and I'm just sort of speaking on behalf of a very big team of the incident response, incident command for the region. And sort of important here to sort of big kudos to the others who've been involved in many of the visits. So we're talking about Valerie Charbonneau from emergency. We're talking about Geneviève Delumière, who is the head of the regional palliative care team. She was the palliative care nurse involved in many of these visits and in following up. Ghislaine Darcier from the paramedic group. Ellie Spencer as well is also who's going to be giving a talk later on her experience. And I'm forgetting people, Shannon Leduc from paramedics as well. There's just a number of people that really need to be identified for the involvement. But given the amount of work done here and the stuff that we saw, it's sort of really important, I think, to leave some legacy from this. This just can't happen again the way it did, and it's very likely that we're going to face numerous waves, and we need to make sure we have an obligation to those involved, that we are going to do our very best to make sure that steps are put in place that this sort of thing will not happen again. First and foremost, need to be some standards for long-term care, so an improved and enhanced physician presence. So the tendency in these facilities and elsewhere is that during an outbreak, bedside presence tends to go down. That the opposite must happen. Bedside presence must increase. This notion that we have sort of virtual care or I'm always available by phone, it's not good enough. What we're seeing, particularly in an understaffed long-term care facility, virtual care is no care at all. They're not calling because they don't have time, and they don't have the familiarity or the awareness of the symptoms they should be calling about. And so a lot of suffering and a lot of distress was going, I think, unnoticed and untreated. And that's really important that we don't do that again. And I just cannot emphasize enough that we just need more presence by the physicians at the bedside. I think we need some metrics. We need to establish metrics of quality, and they may be very simple process metrics because we don't have time for fancy right now. But we need to be, somebody needs to be in there assessing adherence. And there are clearly physicians who are able to do this, and there are clearly physicians who are not willing or able to do this either. That's fine. We just need to have standards for patients. And if those can be met by the MRP, that's good. If those can't be met by the MRP, we need new physicians in there. And that's just the way it is, because there will be another wave, and we're going to see, unless we change something, we're going to see thousands of people probably dying again. Capacity building for palliative care within the long-term care setting. So this has become a divisional priority now for our region that we are going to be taking on and trying to sort of work more with long-term care facilities to bolster capacity among all staff to recognize and treat comfort care, and obviously continuing partnerships, because the interdependence of our facilities is obvious to everybody. So, long-term care and acute care are so deeply intertwined with one another and depend on each other functioning well, that we can't really hope to get out of this, and particularly now as we're starting to reactivate, surgical volumes are going to go up, usual capacities and usual functions of hospitals are going to be restored, and we now have more ALC patients in our acute care facilities than we ever had prior to COVID, even in the ALC crisis. So how we're going to be able to function in that environment is well, the math is very simple. We won't. So we need a better system. We need to make sure that our long-term care facilities are supported, are robust, and are able to take on this role as our hospitals start to reactivate, because we've got a big backlog to get through too. So I'm going to stop there, and obviously there'll be time for questions, I think, later.
Thanks very much for that. There probably is some time now for some questions if people have any. They can pop them in the box. I don't see any right now. I was just there was just two things that kind of came to mind for me, James, when you were talking. One was I remember, with your the article that you had in the CMJ about preparing for a pandemic and stuff. You think kind of with retrospect that there'd be more of an emphasis on education and long-term care and that kind of thing with it. There was a lot of talk about stuff and sport, and it's easy in retrospect to kind of look back on it. But if you were to write it again, what else would you add into that paper? You're muted.
Thank you. I think the problem there, of course, is that there's no question that we dropped the ball when it came to our response. We were expecting one thing and we got another. So from all of our previous experiences with influenza, SARS, etc., I don't think any of them actually had almost their entire effect in long-term care. We were getting ready for a surge that was going to affect our ICU and acute care capacities. For the first month that we were doing this, one of my jobs was I was co-chair of a committee whose job was to open up and find space to decant long-term care out of acute care. And we were putting heavy pressure on long-term care to take these patients over. So we got so far into it before suddenly we realized that we needed to do exactly the opposite. The problems in long-term care, and I'm not a long-term care expert by any stretch of the imagination. I apologize. I don't mean to offend anybody if I'm saying anything too extreme here, but they're really top to bottom issues. They're really quite pervasive issues. And I think that there's a tendency to look for simple explanations, and I don't know that we can. I don't think that there are probably some ideal and much more structural and systemic improvements that we can make first off. But right now, I mean, the gaps we were seeing were astounding to me, right? That physicians just absent. There's a cure for absent physicians. You bring in physicians who are willing to see patients and do work. I understand that people want to stay home and protect themselves if they're covering multiple homes, but you think to yourself, these are people who are going into literally no homes. And if one of your homes is on outbreak, maybe you go into that one. And if another home goes on outbreak and you need to find somebody else to go to that home, well, you cross that bridge when you get to it, but you don't refuse to go into every home. In terms of, and then even if they were present, the issues of comfort and training and expertise are problems. So I think we do need to establish just some very basic standards of medical presence and of actual things that are expected that you will deliver to somebody who is expected to be dying in a matter of days and hours. And start to hold people accountable for that if they're not delivering on that. So just very basic quality improvement framework. Now you're muted.
See, it's all this technology stuff. So there's a question about how do you propose getting ALC patients from hospital to long-term care with the current guidelines around no admissions when outbreak and admissions being on hold every time the patient is tested for COVID, which is happening frequently. One of our current long-term care facilities has beds but is unable to admit, as they're never without anybody being tested. Yeah,
so I mean, obviously transfers and other things are quite problematic. I mean, our numbers, our infections rate are low enough now that I don't think this is going to be a huge issue in terms of transmission. And I think with some clever planning, we should be able to start moving people along. I think the big problem is that these facilities, I actually don't think we've done anything fundamental to fix the issues in these facilities yet. They're not, I don't think, prepared to take back on the ALC role that the ALC patients that are building up in acute care. I think if we did, we'd just set ourselves up for the same problem that we had in wave 1. And I'm concerned about that. What's happening here regionally is that there's a partnership being formed with another building, a 146-bed facility that is basically going to become an extended part of an acute care facility where ALC patients can go while waiting for long-term care to get on their feet. This will be a facility that will be part of an acute care facility. Therefore, it's not technically a transfer, even though they'll be sort of staffed and funded at more of a long-term care type level, but it will be run and managed by acute care in order to sort of enable us to create capacity in order to handle as we ramp things up. I think simple standards for clinical care, nursing care, management, and IPAC, like I outlined. I think until you've gotten that framework up and running from a quality perspective, I think it would be concerning to me to start reloading these buildings, because I think a large reason why they're coping so well right now is because their workload has been cut in half, because half their beds are empty. When you fill them, same issue is going to arise, I think.
I think the other point just to ask about is, that I know you've been in places where you've had the significant problems and issues within, but I'm sure within Ottawa and certainly up our way, there are examples of long-term care facilities who are doing it right and have managed to kind of do it very, very well. Has there been much involvement in planning with those to ensure that they're involved? And the question in the box was also asking, who are the new docs you're going to find for long-term?
Yeah. So the green homes, we call them, the ones that are not in outbreak and seem to be functioning well. I would be very cautious about that. Humans are very good at finding causative links even when there isn't one. So my personal favorite was, I read an article from CBC Kingston explaining why the peculiarities of why, because basically they concluded that there was no outbreak in Kingston because they care more for their elderly than other parts of Ontario. That is just a flat incorrect conclusion, right? You need to understand when you've been good and when you've been lucky. There is nothing different about Kingston than Bobcaygeon, right? And Bobcaygeon got destroyed and Kingston did not. Facilities that didn't get shellacked, I think, need to count their lucky stars. Some of the facilities that got hurt hard and got big outbreaks, actually, I would say were very well run. I was very impressed by some of the clinical care in some of them. And they had very hard to know that was a systemic problem. Good homes and bad homes.
Okay. Maybe just me, but I think James is frozen there.
Yeah, I think his connection might have become a little wonky. Maybe while we're getting that sorted out, maybe we can move on to Melissa Declan, if she's available.
Yeah, Catherine, have we been able to get Melissa connected?
Unfortunately, she was connected through Dr. Downar.
Oh, so maybe what we can do while we're getting that done, I'll kind of have a chat through my presentation and just have a chat about what we were doing here in Renfrew County, if that's okay, and so we get them up and going. Okay, so I'm just going to load up my slides here. So bear with me here for a second, and hopefully, here we go. I hope everyone can hear me okay. I'm getting a warning. I've got bad network quality here too. We're overloading the network, I guess. But
you're coming through clear.
I am. Great stuff. Okay. So I was asked when the COVID started to help with our Renfrew County Virtual Triage and Assessment Centre, VTAC, to kind of look at how we might include palliative care as a response. And there's been a very robust response to the COVID in Renfrew County, and the development, kudos to many people in Renfrew County, but especially Dr. Fitzsimon in Arnprior and the paramedics and many others as well, who've been involved in getting a very robust, comprehensive approach to dealing with COVID-19 here locally. And it really is about trying to provide as much care virtually or with in-home assessments to reduce people needing to come to hospitals or their facilities where possible. So people will call in to a number and then get connected with a physician if they didn't have availability for their own family physician or didn't have a family physician, and it didn't matter what the clinical problem was, and it would be assessed and then triaged out to either be dealt with over the phone or have a paramedic visit or be directed towards a hospital or a facility. But through this, we were able to kind of develop a system where people actually were able to have virtual primary care, some virtual acute care, and in fact, there was the ability to have some virtual monitoring in the community with acute care wards, virtual palliative care, and then supporting our long-term care facilities as well. As part of our, and I'm not going to go through every bit of this, and this was going to be a short talk at the very end, but there was an awful lot of work went into our palliative care bit to try and sort out what needed to be done, and we had great, I would say, fantastic support from physicians, from a whole host of partners. There was multiple meetings. There was a group of physicians from every single medical community across Renfrew County joined in. And we developed a process, and the whole goal of it was to try and be available and able to manage as much palliative care right there and then within the community. At the time when we started, we were concerned there was going to be large numbers of patients with COVID and needing support within the community, and that just didn't turn out. In fact, we've had very, very low numbers of COVID up here in Renfrew County. There's just been one death in the whole county. But what it has done is really make us look at the way that we're delivering palliative care anyway, and there's been a lot of work done to try and improve that. This is a flow sheet which I'm not going to go through in any great detail, but what it shows is that we're really trying to involve a whole system change for how we're approaching palliative care delivery. And as part of that, and what was new was the use of paramedics and our community paramedics to provide a lot of this care. And we call it stopgap care. So if somebody had an acute crisis within the community, because of our geography, paramedics were often the first to visit and to be in the home and able to get there rapidly, much more rapidly than our home care nurses, and especially if somebody was not already connected with our home care team. The paramedics, especially the community paramedics and advanced care paramedics, all carried some medications themselves. They'd been carrying ketamine, fentanyl, morphine, and midazolam. And we developed medical directives and training where they could provide some medication in the home for immediate symptom relief where needed. We've also worked on processes where they've actually aligned with our symptom management kits and broadened out the medications that they're using so they align better, and have started using subcutaneous lines for palliative patients rather than IV lines, so that home care nurses who come in behind them can continue on with their care. So, although we've had very low numbers of COVID patients, what it really has done, this whole process has really been to really mature and grow along how we're delivering palliative care up here in Renfrew County. I have to say I'm delighted to have got to know more physicians over the last couple of months who are working hard on palliative care. And we've now developed a network of physicians who are who've been doing a lot of palliative care either on their own or in small groups, who are now meeting regularly. It started off to develop a process for COVID. It's now become a support and mentoring network for each other. But we've also all agreed to take on any unattached patients who need any kind of end-of-life care so that they're not left hanging. I think there's been a lot of work done on developing and deepening the relationships of all our partners across Renfrew County. But I would say that there's been a couple of really great process improvements that we hope we will see continue on beyond COVID. The first, I think, is our community paramedics doing stopgap palliative care, and whatever system comes out of beyond this COVID pandemic, I think community paramedics will have a key role in how it is delivered up here, for sure. They have extended and changed the way that they deliver medications and the types of medications they're carrying, I should say, so that they align with what we would be prescribing within our symptom management kits. Not only that, though, we've also did a lot of work in making sure that people can get expedited access to medications so that we don't have to transfer people to the hospital for lack of medications. And Mulva Health Pharmacy, who currently delivers all our medications for Renfrew County, has really worked very, very hard to deliver them, often within a matter of hours or less, depending on how far they are from the pharmacy, right out to the home. And also, we've done a lot of work with our home care colleagues to try and expedite and improve the referral process and make that as easy and as seamless as possible, which we hope will continue on. Initially, when all this started, a group of us were providing 24/7 call through the VTAC program, but the call volumes, and as James has pointed out, actually the call volumes were actually quite low. We had very low numbers through it, and it wasn't sustainable for us to continue to do that. So we're now in a process of shifting this and involving the regional palliative consulting team, who would link in with the more usual family doc who'd be doing the VTAC shifts as well. So it continues to evolve. So I think bottom line for us here in Renfrew County is that although COVID caused a considerable crisis in the way that we had to change the way we delivered care, I think what we've seen is a tremendous number of opportunities for us to change processes, and we're now seeing ways that we can really grow how we deliver all kinds of care, but especially our palliative care, which should sustain beyond this COVID crisis. So if there are questions about that, I'm happy to talk.
Sorry, Declan, I'm just unmuting here and just going through the questions. There were some sort of generic questions. No, I shouldn't say generic, but questions regarding the long-term care situation again. I don't know, James, are you back on?
Yes, I'm back on. Sorry, my Wi-Fi, my internet connection here in my house is bad now for some reason. I don't know why. Sorry about that.
No problems at all. Just going through the list of the questions here, and there's other questions about in terms of advocacy for long-term care resources or changes to the long-term care system, and who would own the IPAC and the training piece if that was a large gap.
I mean, you know, I guess this is a broader issue for all, and I at the risk of saying something I may regret later, I think it was very. I think we're very good at giving people a pass on this lapse. So I'll tell you a tale of two cities. So you have facilities full of people who claim that they were not, told how to use equipment, etc., and were very stressed out about the whole situation, and that's why they chose not to come to work. And there were tons and tons of healthcare workers in long-term care that went down with this. And then you look at home care. So in home and community care, nurses going into people's homes all the time, tons of community transmission going on at a certain point within households. There was no education, nothing available for these individuals for training for how to doff and don in someone's house. Or even to get equipment. They managed to find the equipment, and they went, like everybody else, they went on YouTube. Can you hear me?
Yeah, we can hear you.
Yeah.
Absolutely.
So, like everybody else, they went on YouTube and figured out, because somebody else had made a video to teach them how to doff and don. And they learned, they taught themselves, and they did it properly. And to my knowledge, I'm only aware of one home visiting physician in Ottawa who got COVID. And you know, it strikes me that a certain degree of responsibility for this has to fall on individuals. That, you know, again, I don't think in this day and age it's you know, an appropriate excuse to say no one trained me. When you're aware, if you're aware that something's an issue, you need to take some responsibility and ownership yourself. But at the same time, facilities have to take responsibility for not training people and not ensuring that among the many things that they're training people how to do, that this was not up to date and ready. Long-term care facilities in Hong Kong did this, and they were doing them quarterly. They had you know, PPE training up again. So I think that's a big part of it. But then more broadly, we as a region, we have public health, we have you know, we have the IPAC experts. Most of the IPAC experts come from acute care. So that expertise and that assessment has to be, you know, to some degree, at least in the interim, coming from acute care, with in a sort of longer term framework, as we sort of beef up things like assessments and quality control frameworks for quality assessment frameworks for long-term care. I think that has to come with assessors and trainers and champions that you build into the building. So I would say that the responsibility is multi-tiered. But I would say what that means is that we are all responsible for making sure long-term care is IPAC'd up, because if they're not, the consequence falls on all of us.
Thank you for that. There are some other questions, but I'm conscious that and I'd like to give Melanie enough time to go through her presentation as well, and we'll try to get through all the questions then at the end of this, if that's okay. So hopefully, Melanie, you're on the line.
Yeah, I should have Melanie. Melanie, are you there?
So while she's connecting, I'll just
Can you hear me now? Yep. Can you hear her?
Oh yes.
Can everybody hear me? Can anybody hear me?
I can hear. Yeah, we can hear you.
Okay,
Hi.
fantastic. I
Hi,
know
Mel.
I'm watching in the presenter view, so there is a bit of a delay. I've got all my audio turned off and just talking through my phone now. So I'll count on you guys to let me know if this is a go or a bust. So
Oh, it's a go.
my slides should be coming up, I believe.
No,
Yes, they're up. Oh, they're up. See, there's that delay. So for those of you who don't know, well, my name is Melanie Spenceley. I'm a nurse practitioner with the Regional Palliative Consultation Team. You can go ahead and advance the slides, Catherine, if you can. For those who don't know, the Regional Palliative Consultation Team is a community-based group of consultants working with primary care providers, retirement homes, long-term care homes, and some community hospitals, with the goal of building capacity for the delivery of palliative care. At the outset of the COVID pandemic, as a team, we were really looking to develop some ways to leverage the skills of our team and create some capacity to deal with a potential surge. As the usual part of our work, we have really good links into these long-term care homes, retirement homes within our region. And so when things got a little bit crazy in these long-term care homes, but we're fairly okay within the hospitals, we really tried to switch gears towards that. So we did get linked up with the incident response team that was really led by the Ottawa Hospital and with the community paramedics. So we had consultants from our PCT available to assist with assessment and in some cases take on some of the provision of care, in particular in a retirement home where you know, medical assessment was not present. So the bulk of my experience with COVID positive patients has been at one of the local retirement homes that has been on quite an extensive outbreak. There are some nuances with working with retirement home in that they are for-profit entity and they are privately paid for by the residents, who essentially are renting a room in the building, and then additional services are bundled for purchase. Whereas in long-term care, of course, we have standardized in cost and subsidized in some cases by the provincial government. In the particular home I was working in, the initial positive patient was April 27th. And then so once a couple of positives and symptoms started popping up, there was a mass swabbing. And in total, the initial infection rates were 28 residents out of 61. In addition, there was initially 12 to 14 positive staff members. And unfortunately, throughout the course of the last couple of weeks, the numbers have gone up again. They were flagged to the response team around May 8th, and this was following 4 911 calls in a really short time frame, like within hours, essentially. So as I had mentioned, and as James has alluded to, there's been physician involvement who prior to the outbreak could visit the home, but had not been to the residence since early March. Available by phone, however, during daytime hours, of course. But again, the staff within the home needed to be able to identify issues to call him for, right? So medical presence wasn't there. So with the next slide, please. So coming into the home, certainly I was looking or preparing for a worst case scenario. But overall, my initial impressions were fairly okay. All of the residents looked well, relatively well, and particularly in their memory care unit, residents were very well attended to. They were well groomed, you know, what really should be the very basic standard of care. But knowing what was happening in other places, I felt better seeing them. So there was a good supply of PPE with stations set up outside of each room. They had gowns, gloves, cavi wipes, hand sanitizers, individual garbage bins that were touchless so that you weren't opening and closing garbage cans. There was staff cleaning surfaces, doorways, chairs, everything. And wandering patients actually were fairly quickly redirected back to their rooms, so there wasn't a lot of mingling outside of rooms. In the upstairs hallways where it's a more independent living, everything was very quiet, so residents were actually very cooperative with staying in their rooms, and they've been there for longer than 4 weeks now, which has been quite hard for them. Over the course of the outbreak, public health was providing some in-resident support for IPAC education, and certainly our team did provide feedback with each visit. Again, the most common offense was food, these snacks and treat drops being dropped off and staffed in common areas, assuming that the common areas were clean, but we know that that's not always the case. Staff was slim. They were overwhelmed, and partly I think that was due to our arrival in some ways. There were some concerns about the availability of a nurse for overnight shifts and things like that, but the retirement home did access agency staff to fill in gaps, so there was, in fact, nursing there and present. The residents themselves were really quite variable, and I think it was quite interesting to see such a wide spectrum of symptom burden. Our assessments, as James had mentioned, were very quick into the room, assessing general appearance, and many of these patients looked well. We measured their OT-SATs for all of the positive patients, and then this is where we would identify some of these asymptomatic hypoxic patients. So they looked well, they felt well, there is no tachypnea or work of breathing, but their OT-SATs were 85%. There was a small cohort of patients where their symptoms ranged really from general malaise to mild upper respiratory symptoms. There were several residents identified who were really on a downward trajectory towards end of life. Interestingly, these patients did not appear in respiratory distress, presented in a delirium, a sharp functional decline, very little PO intake, and with these folks, their O2 sats were quite variable, but for the most part remained over 90%. So again, we had, I have a summary of some of the symptoms we saw. Often these symptoms were remitting and relapsing and really varied from visit to visit. So I was visiting this home for the first couple of weeks, almost every second day, with the community paramedics and some physician partners. During that first 2 weeks, we did have 2 residents pass away in the home. The first death, really the patient had become quite delirious, likely a combination of the viral infection and dehydration on top of advanced dementia. Second resident also had advanced dementia, had an unwitnessed fall that led to an injury in an emergency room visit, but this really triggered a precipitous decline for her. No respiratory symptoms. She really just became weak, lost her ability to swallow, and quietly passed away. So, in terms of actually managing these symptoms, I used the Champlain Symptom Management Kit. We had 5 residents that we identified as being concerned about that we did order medications for. We used the SMK just because we knew that medical pharmacies stocked the meds, whereas we weren't as confident that the contracted retirement home pharmacy would be able to gather these meds and get them out to us for same-day delivery. We also wanted to make sure we had enough medication to respond to any changes in condition or newer emerging symptoms. All of the patients were opioid naive, so you can see we started with very, very low doses. The only changes that I made to these meds throughout both of these residents' trajectory was switching from a PRN dosing to a regular dosing system, and that was mostly to ensure that they in fact did get their medication and were comfortable and had some form of regular assessment from nurses. We involved the Lynn Home Care program for all of the patients that we had identified as potentially requiring palliative care or end-of-life care. And this was really to assess in the symptom management piece, but also to help us access supplies and equipment in a timely fashion. So my next slide is the actual symptom management kit, which I'm sure many people are very familiar with. There is a long-term care version that has been adapted from the outset of the pandemic. Medical pharmacy doesn't provide PO or parenteral meds through the home care program, so any additional acetaminophen or medications that we used for PO symptom management went through the client's home pharmacy. So we did have some residents who became dyspneic during the course of their illness, but were well enough that they were swallowing with no issues. We used low doses of hydromorphone elixir, and really this was very time limited, a few doses, and then sort of had moved through that symptomology. For residents requiring oxygen, we ordered this through Medegas, and I put them all under palliative funding only because this was really my quickest way to get the oxygen into the home. And we provided standing orders for all of the COVID positive patients so that the nurses in the home could just go ahead and start without having to order a unit individually. The retirement home did agree to rent a unit to keep in stock so that we always had a surplus of one in case we needed. So in total, we only needed 4 compressor units in the home to date. We had a few residents that benefited from IV fluids, and we utilized the community paramedics to administer this. These patients were on memory care, and being able to go in and give them a bolus over 1 to 2 hours versus having them connected for 24 hours to an IV or hypodermic crisis just worked better logistically. Staff were good to start pushing a variety of fluids, soups, jellos, puddings, and they did keep good track of who was eating and drinking what for us. A big part of what we did was calling families and reaching out, particularly patients who we had concerns about. We wanted to review goals of care for patients who weren't making healthcare decisions for themselves. There was a lot of reassuring them, which was appreciated, reassuring that we would be back to reassess, and that for some people we would be staying involved for their palliative care. On my last visit to the home, so I was last to the home last weekend, and the large majority of our residents that we have seen have remained well. Some have met the criteria to be considered negative, and symptom complaints or triggers for us to see the residents now are becoming a little bit more vague. And then when you get to the room and assess them, they're actually non-existent, and it's more of a social need, I think. So I think we are starting to see some of the mental and social effects of their isolation. In total, I had brought 6 patients onto our PCP caseload to follow closely with the palliative approach to care. 2 have passed away, 2 have recovered completely, and 2 are a little bit more slow in their recovery, but moving in the right direction. The home had 2 other residents who did pass away in hospital. So as we're moving away from the height of this home's outbreak, what we're seeing now is a really strong need for a transition back to good primary care to stabilize and optimize all of the residents. In terms of barriers that we identified in the retirement home setting, certainly I think the biggest challenge facing the home and continues to be is staffing. In the retirement home, there's a heavy reliance on community service providers, so both personal support work and nursing that comes in through the home care program traditionally. So when this resource became more scarce, and also that we are trying to balance the amount of people coming in and out of the home was really in a scramble. On top of that, they did have staff members become ill or cohort to other places of employment. Not unusually, retirement homes typically have 1 nurse in the building on the overnight shift, and when you have multiple sick people, that's quite a stretch. I had spoke to this earlier, and I think James alluded to it as well, but there's, again, a strong reliance on the home care system within retirement homes. Professional staff in these homes are de-skilled, so, they're not putting in sub-Q lines, they're not comfortable with intermittent injections or even assessing for symptom management. So this did create a bit of a slowdown in the sense that we had to refer to the home care program just to be sure that at least our very sickest patients would have some oversight for the symptom management. Again, in retirement homes, they aren't stocking emergency boxes of medications, and they really have extremely limited supplies, which created, again, another dependency on the home care program in order for us even just to bring in sub-Q lines and Foley catheters, for example, or syringes even. On my final visit there, or my last visit last weekend, I could also sense maybe a bit of IPAC fatigue, I'm using quotation marks, or maybe a sense of complacency as people are recovering, and I'm not sure if the sense of risk is as strong as it was 2 to 4 weeks ago, but it's a strong reminder and feedback that we had again provided that we don't want to lose ground on this on the IPAC. So certainly there was some really bright spots in providing care and assisting with these retirement homes. The homes were all very welcoming. The staff were very appreciative of help. They were open to and considerate of our recommendations, even when we forced them to not accept donuts anymore from Tim Hortons, right? Like that's a big one, but they were open to it. And, you know, they were able to, with assistance from the home care program, care for these residents in the home. And particularly where end-of-life care is not something that they would normally manage. There's some empowerment of staff to gain new skills. I set up a policy and procedure for inserting sub-Q lines, provided them with some learning documents, and helped them with inserting sub-Q lines. So it seems small, but it's actually a pretty big thing to empower these nurses who certainly have the ability within their scope of practice, but traditionally have not been empowered to do so. And personally, it was really quite an excellent experience to work with the paramedics and all the TOH docs coming in. There was emerge docs and anesthetists and retired family physician has worked with us, and they really have brought balance to my palliative care lens. It was a bit of an insecurity of mine that I would go in and really look at, like, turn everybody, like, well, we can all benefit from palliative care, and it doesn't necessarily mean that everybody needed end-of-life care, right? So knowing the difference between the two, and it was really a very good experience for me. My final slide, I just wanted to put in just a little word on non-COVID palliative care in the time of COVID. Certainly, we also were able to really, in anticipation of a surge, minimize our caseload to some degree. But patients are still dying of our usual terminal illnesses out in the community. So we did see a lot of referrals come into us, quick discharges from hospital. Patients were very anxious to get home where they could be with their families. Patients are more inclined to stay at home right now, not necessarily because they're afraid of COVID in hospitals, but more because of visitor restrictions. Our residential hospice and our PCU have some limitations on visitors, but they have remained open and a great option for patients, non-COVID patients needing end-of-life care or specialist palliative care. And I have found that the family doctors and the community palliative doctors have all been super willing and super flexible to work with their patients and accommodate care at home. So as a community of providers, really, we have we really just have wanted to make sure that the palliative care continues and that nobody's left behind. We have really not experienced any medication shortages. Thankfully, our pharmacy has done a great job of mitigating that with part fills and things of that nature. And I think all of us are using a bit more caution with quantities, etc. So that's it. That's been my experience with COVID and palliative care.
Melanie, thanks so much for providing a really fantastic overview of what it's like on the ground, and I think it's been very helpful. There are some questions on the line. If you're open to answering a couple, and maybe I'll go through them. There was one at the end that might be appropriate. There was a question wondering about if there was effective strategies for wandering patients. Maybe less of an issue on a contained outbreak unit, but long-term care have been criticised both for using restraints and letting people wander. I don't know if you or James may have some suggestions on trying to manage wandering patients in a COVID outbreak?
I think in my experience with the retirement home setting, the memory care unit that we were working with had 21 residents, 19 of whom tested positive. Initially, they were keeping everybody out of communal area, doing massive cleaning. And what I really saw was as soon as somebody came out into the hallway, staff were intervening to direct them right back into their rooms. How sustainable and how doable that was across 24/7, I'm not sure. And at some point, what they did, and they had consulted public health about this, was they actually brought out the COVID patients and kept the non-COVID patients isolated. This improved, like, PO intake and some of the social frailty that we were seeing as a result of isolation, and we continue to see. I think probably that helped. I think it was a very different experience in long-term care, though. So I'll let James speak to that.
Yeah, I mean, you're asking a very good question, and I mean the answer is that when someone's a wandering patient, even if you try to restrain them, it's, as you say, chemical or mechanical restraints on such individuals are very unlikely to work unless you're either prepared to tolerate somebody in 4-point restraints who is screaming for hours on end, or you're going to more or less have to sedate them. And I don't think either of those options are good. So really the question then turns to one of managing and cohorting the patients appropriately. So you're going to take your negatives and put them with negatives and positives and put them with positives so that it doesn't become an issue. And that certainly was a big factor at one of the facilities we visited where we just at one point it became impossible to even track who was in which room because there were so many wandering patients, and 3 of them were in one room, and it actually wasn't the room of any of the 3 in it, and none of them, we couldn't even figure out which patients were which. They wouldn't let us look at the name bands. So it just gives you some idea about how challenging it is to actually come up with a reasonable approach to managing this beyond cohorting. I haven't seen one. I think that's the only option.
Yeah, and Geneviève has commented about saying that she says, I don't think they have a choice but to let them wander around. There's no way to keep them in their rooms. So strategies to maintain, to allow that to happen, I think are needed. The other questions, I think there's a lot of questions, can group them together, but about IPAC and PPE and training. And I think the questions kind of, I think revolve around the fact that, long-term care facilities in particular were underfunded and understaffed. And I guess the question was like, who is the mandate for training the staff and ensuring the adherence to the IPAC procedures, especially given how understaffed and underfunded long-term care facilities have been. And kind of going forward as we may be experiencing future waves, how we I guess as a system think about supporting this in a longer term. If anybody wants to tackle that one.
Yeah, I mean, again, I in trying to answer it before, I think the point I was trying to make is that it's kind of a multi-tiered responsibility, right? That there are similarly underfunded sectors of our healthcare system where it's unclear whose responsibility it is to train people for things. Home and community care, for example. Home and community care has done a very good job of making sure that they haven't gotten infected, and through use of self-training. I mean, there's a lot of people taking responsibility for their own training, which I think is really important to do. I think the facilities cannot be, facilities must also be held accountable for this as well, and certainly making training available and making sure, particularly as we move towards future waves, that everybody, like you can't work in this facility unless you've been IPAC trained. But then there are many aspects of IPAC training and acculturation, if you will, that include things like creation of champions, audits, periodically doing sort of donning and doffing, supervised donning and doffing exercises similar to what's being done in Hong Kong, which are, I think, models for us to follow. You know, I guess the same question could be asked for whose responsibility is it in any sector, like acute care. Like, you know, if I got COVID, I'm not going to turn around and blame the hospital, you know, for failing to train me. I mean, it's as much my responsibility to make sure I get trained when I come in to a facility where I have a chance of contracting a communicable disease, as it is for the facility to make sure that I have access to such training. And the auditing obviously needs to be in place as well. The reason I think that the auditing also is important is because to recognize that, you know, when we're in situations of outbreak and the R naught is greater than 1, it's not even just about protecting yourself, it's about protecting your colleagues, because if every infection leads to at least 1 or more infections, really you're protecting yourself and everybody else when you're doing it properly. I don't know if I'd love to hear what others have to say.
Yeah, I think from my perspective, what I would say is, you know, even within our hospital here, you know, and, you know, compared to any of our long-term care facilities, the amount of resources that are available for IPAC and for training are huge compared to anything even within primary care or other sectors. And certainly, people still struggle with managing and their PPE appropriately and wearing it appropriately and using it appropriately, and there's still issues with it on an ongoing basis. I think what's encouraging for me has been some of the partnerships that have kind of grown out of this pandemic, and one of the partnerships has been the outreach of resources from hospitals into communities and into long-term care facilities. And I think you know, the expertise lies within some of the hospitals. They have people that they can work along with them, and I think even in the short to medium term, I think we need to kind of continue to work at supporting our long-term care facilities and our retirement homes to continue to build capacity to not only care for the patients that they have there and to develop the skills to be able to do that and grow them, but also to support them so that staff themselves also are able and confident, feel able to kind of manage not only the care part of it, but also themselves managing their PPE themselves too. I think we do need to continue that on and going forward. There's a couple of other questions, more comments. Melanie, you've got a couple of. I'll just read them out. Excellent presentation, Melanie. I hear in your summary statement the concept of IPAC fatigue, such profound stress on staff and the collateral damage of prolonged isolation and sedentary lifestyle on the other residents, all very important concepts, I think. I don't know if you'd like to make any more comments on that, Melanie?
No, except that I absolutely have the utmost respect for the staff that are working both within the long-term care and retirement home, and they're exhausted. They really are, and there's been a core group, particularly in the retirement home we've been working at, that have been pretty tirelessly working. So just my utmost respect to them. And as they're coming out of this, we're just really trying to reinforce that just this final push to keep vigilant with our cleaning practices, donning, doffing practices, just as so we can kind of get through this final push. I would also just mention, and this speaks to the earlier comment in terms of IPAC, is really that a lot of employees who are becoming infected aren't necessarily providing hands-on care, right? We have kitchen staff who are infected. We have cleaning staff who are infected. So it's such a wide reach that all need to be included in training and as valued members of the team, of course.
Thank you. And again, another one, Melanie, yours may be read, but kudos to you. It says for your actions in your presentation, found the positive, practical, and working to use the resources available and not just criticizing. So good job. There are, I think, ongoing kind of questions about just the IPAC, and I think it's the same kind of thing that, you know, I think there are issues with IPAC at all levels, even within hospitals. And just one comment that, you know, that on a COVID ward, that people were spending the bulk of their time in the rooms were nurses and not doctors. They feel that PSWs don't have the skill set to retrain themselves. At TOH, they use a buddy system on the COVID ward, one MD watching the other don, and more importantly, doff the equipment. And they also had the luxury of IPAC demonstrations. PSWs and RNs at long-term care and retirement homes deserve the same support, not self-training, and supporting teams giving each other feedback. So, one last comment, I think it's important to acknowledge the amazing expertise that long-term care homes have. The staff are extremely knowledgeable about their residents. There simply wasn't enough staff. And I think that really does highlight the bulk of the problem for sure. So I don't think there's any other questions. I don't know if any of the presenters have any comments that they would like to make before we finish up. We're a couple of minutes early, which is always good.
Could just throw in a comment here, Declan. I hope I didn't come across as being overly critical to people as a whole, and I don't think that was what my intention was really, but I think it is, you know, in terms of being asked pointedly about questions about who's accountable, I do think that the accountability does need to be shared at multiple levels, and not just at the management level or having, you know, a different authority come in, because simply, you know, a lot of this is also practical, because there aren't, outside of acute care, there really aren't a lot of people who could come in and do extra training or do extra assessments right now. So we are really going to heavily depend on people within their own sectors to start to step up and do this. Staffing levels are a big issue as well, to the last comment's point, that, you know, having people to pair off and be a officer are really, really important. But again, with the amount of donning and doffing that goes on, that isn't always a practical approach. So I just wanted to make sure that I feel like my comments were perceived as being overly critical. I do regret that. I don't want to be overly critical of individuals, but just highlighting the group responsibility for the issue.
Thanks, James, for that and the clarification.
Melanie had one more comment, Declan.
Sure.
Oh, I've kind of lost my train of thought because I'm into these comments here on the side, but what I would just say is thank you, first of all, for having me, but also, again, can't underscore enough the work and that the people in these facilities are doing, and their intimate knowledge of these residents at their baseline, and being able to identify when things were a little bit off for them was really really awesome. And then also the entire team that sort of has been so flexible and willing to come together. You know, Dr. Charbonneau provided her cell phone number to this retirement home, knowing that they didn't have after hours coverage, and you know, that, like, little things like that go a long way in humanizing this and really just showing, like, or just having a sense of camaraderie that in our usually more siloed system isn't necessarily there. So it's been a valuable experience.
That's great, thank you. I think for me, you know, the lessons that I'm learning through all of this is, when it all started, there was so much concern about, you know, symptom management and trying to manage patients with significant respiratory issues, and it's really kind of developed into, you know, how we need to be looking at our whole healthcare system and really thinking about how our frail elderly people or patients and our community are looked after. And you know, I think that's probably been the most important lesson of all of this. And for me, you know, we've had very small numbers up here in Renfrew County, to hear practically from both of you what it has been like in the cold face of dealing with all of this, I think has been really rewarding and helpful and really practical. So I really appreciate both of your input and advice and expertise on this. So thank you for agreeing to come to this today. Sunil, I don't know if you have any other comments to wrap this up.
No, I echo everything you just said. That is the lasting legacy of this, is how our health system needs to improve, particularly for those of the most vulnerable of us. Also, thank you very much to all three of you for participating in excellent presentations and giving us a window into what's happening in these communities. As a stepping back, as I mentioned earlier on, this is part of a series of COVID and healthcare. I guess we can term it that now, COVID and healthcare. And our next talk is on COVID and pregnancy related issues. So we will send out an email and a flyer out to relevant groups, and please spread the word. Thank you very much for joining us today. And again, thank you to our presenters for a great evening.
And I think the last point, I think these sessions are recorded and they will be available for people who haven't been able to attend. If you know people who haven't been able to attend any of them, they will be available, and the link will be sent out once they're up online.
That's right. Thank you.
Thank you so much.
Okay, with that, everybody, have a great night.